by Dr. Martin Stiles, who is the director of cardiac electrophysiology at the Waikato Hospital. So Martin studied medicine at the University of Otago, and then completed his training in cardiology at Waikato, and then in the UK at Edinburgh and Leicester. He came back to New Zealand, to Hamilton after that, and then got a PhD at the University of Adelaide, working in atrial fibrillation. So his research interests include atrial fibrillation, implantable cardioverter defibrillators, pacemakers, arrhythmia, and so on. And so today he is going to talk to us about some technology that's useful for cardiac arrhythmia research. Over to you, Martin.
Thanks very much. Thanks very much for inviting me to speak. All that is true, except between the UK and Australia. I actually lived in Auckland, but could only last 7 months, and decided to head back to Waikato, where the traffic was less and house prices were more reasonable. I thought that with an audience of bioengineering people, I should really talk about technology, because I'm not entirely sure what goes on in this building, but my imagination tells me that you guys are thinking of clever new ideas to translate your research into clinical work and trying to bring those eventually to the clinical world in medicine. And so I've had a bit of experience in going from the translation of preclinical work to clinical work. So I thought I'd share a little bit about that with you today, hence I'm clutching this catheter. And also just to give you a little bit of a background about arrhythmia research, particularly atrial fibrillation, which is my area of interest, and I know it's many of yours area of interest as well. So I was thinking about this talk, I was thinking, well, what roles do we have in, the people around the corner there, what roles do we have for technology in arrhythmia? And so still a major issue for us is rhythm diagnosis. And so we're still relying on somebody having their symptoms and getting an ECG at the time. And so whereas previously we were having people wearing sort of Walkman-like devices, Holter monitors, we're now into the area where we've got smartphone ECGs, we've got wearables, and even in the more complex, instead of the ambulatory space, we've got the clinic space. We've gone from 12-lead ECGs to now multi-lead ECGs or ECG imaging. Speaking of imaging, we've got multiple ways of doing it: CT scans, MRI scans, ultrasound. And what I do in the EP lab is I do electroanatomical maps. So that is where I have catheters up into the heart, I have patches on the body which tell me where in 3D space my catheter tip is, and I can create a geometry of the chamber of interest, and I can annotate voltage, timing. If I do an ablation lesion, I can say, where I've burned, I can annotate something that I might want to come back to later. And I can merge my anatomical image with some pre-procedural imaging like CT or MRI. So this sort of stuff is becoming increasingly important. And then there's also a role in technology for treatment, drug design and delivery. And I think delivery is important. It's not just about the drug, it's getting it to where it's needed. And then, I won't talk a lot about it today, but pacemaker and ICDs, that's another area where we, there's a big role for technology, not just in the hardware, which is comprised of the pacemaker itself and the lead. We now got leadless pacemakers, but also the programming and things like battery life parameters. And then lastly, cardiac ablation catheters, and this is where I've had a bit of a role in trying to get better catheters into the heart safely and to do their job effectively. So I wanted to start off talking about the Helix reusable dipolar EP catheter. So this is the here. This is made by CathRx in Australia. It's an Australian company, and currently, well, at least until recently, we were using single-use catheters, and the cost of these was around $900 each. Most EP studies require one of these catheters, so there's $900 in the bin at the end of the case. We recently negotiated the price down to about $700 or $800, I think, but it seems a waste to me. And so what we what they designed in Australia was the idea of a modular catheter here. You can see that there is a, if I can use a laser pointer, here we go. So this is the disposable bit. That's the catheter here that goes in the bin. But the expensive stuff, the handle and the the wire. So this is, you can see there's 10 poles, you probably can't see it, take my word for it, there are 10 poles here. And I can control that catheter with this handle. And I can get this up into the heart, I generally try and torque it into the right place, move it, push it, pull it, relax it, get it into the coronary sinus as I see fit. And this is how it goes together. So you've got the catheter here, this bit comes apart and comes off the device. So this bit here goes in the bin, this bit is recyclable. So you can see now, you can see the pull wire perhaps, if you know, and inside the catheter it looks a little, it takes a slightly different bend. We had to do a few modifications to this catheter. We had to in fact weaken, this is nitinol, it has a very strong memory of where it wants to go back to. It's really hard to even wrap, to transport here, to be honest. But we had, because it's so strong, we had to put these little cutouts here in order to weaken the catheter, to make it bendy, because you didn't want it too pokey in the heart, because poking holes is generally thought to be a bad thing. This is what it looks like on a radiograph. So this is our decapolar catheter here in the coronary sinus. So we come up and through the vena cava into the right atrium and out the coronary sinus, which is the venous drainage of the heart. We do whatever we need to do with the catheter, and then we wrap it up and we put it into a tray for sterilisation. So this bit comes back to us, and we open a new one of these. These things cost 50 or 100 bucks. These things can be used 12 times. So, I mean, I think ecologically it's quite nice, and certainly economically it's quite good. So where have we gone with this? Well, we're just about to present this later this month in Taiwan at the Asia Pacific Heart Rhythm Society. This is our first in-man experience with it. So, we were the first ones to use it, and we did 60 patients, and we looked at how long it took us to get there, whether it fell out, whether we could get it in. Sometimes we couldn't get it in. If we couldn't get it in, could we get a different catheter in? And just a sort of a proof of concept. Another bit of work we've done at Waikato is the temporary pacing lead. So temporary pacing leads, if you have the misfortune to have a bradycardia, say complete heart block, you come into hospital with a heart rate of 30, perhaps a kind of collapse, then you may get a temporary wire, and which will keep your heart at a decent rate until such time as a permanent system can be fitted. But they're also used during procedures, and the one procedure where the temporary wire is quite important is transcatheter valvular aortic valve replacement, so TAVIs or TAVRs. So the valve replacement, instead of having an open chest, the valve's put up through the artery, a wire's put across the aortic valve, which is usually stenosed, which is why you're doing it, and you're putting a artificial valve within that aortic stenosis. So it's revolutionised aortic valve treatment, because you can imagine there are some patients who are not well enough to have their chest opened, put on bypass, have the valve replaced in an open fashion, chest closed, and spend 3 days in ICU recovering. Much easier if you can do it through the groin and they're out of hospital, up and around the next day, out of hospital in 3 to 5 days. But because the aortic valve is really close to the AV node, there's a considerable incidence of heart block, and about 15 to 20% of patients will need a pacemaker after the procedure. So while you're doing the procedure, you put in a temporary wire. And the temporary wires that we have had, they're pretty basic. They look a bit like this, and they just sort of sit there, and you hope that they stay. Whereas this company, which is Bioengineering Medical, they felt there was a need for a more reliable way of doing this. So this is the tempo lead here. It has a little inflatable balloon here, and it has little stabilizers on it as well, which hook it into the muscle. It's got a flexible tip, and it's got little radio opaque markers to see so you can see where it's going. This is what we did. We've published this in the Journal of Invasive Cardiology, but we presented it at a couple of conferences. We got 25 subjects, 14 were aortic valves. I did the first in man of this in an EP study. We chose EP studies because electrophysiology studies, the first guy, he's 35 years old, he's otherwise well, he's very robust. If anything went wrong, it was much better than an 85-year-old woman who had aortic stenosis. So we tried it out on them first. They were very kindly allowed us to do this. And so we had a safety endpoint here, absence of any problems, technical feasibility. We got it in place in 23 out of 25 patients. And there was one patient, who had it for 5 days. She had it in her jugular vein, which meant that she could ambulate instead of a femoral vein. And because it was actively fixed in place, she could ambulate. And that's a big thing if you've had an operation. If you can get out of bed, the sooner you're better, right? That's deconditioning. So I was going to show this little animation for about a minute of what this catheter does. This is it here. You can see these little tines here that stabilise it, and there's a balloon on it as well. So you put it in the femoral vein, and you inflate that balloon. And the balloon kind of acts as a sail to bring you up into the heart. You push it as well, but it sort of sails you up. There's much the way a Swan-Ganz catheter works, if you're familiar with those. It comes up here through the IVC and through the tricuspid valve, and you can turn the balloon down at this time. The idea is you're aiming for the right ventricular apex, which clearly this one goes straight to. It's got a deformable tip. And you can rotate this marker so that you know where your tines are going. You want your tines to go into the septum, not the free wall, potentially, and then you push that balloon up, which is eccentric, pushes you towards the septum, and then you deploy these little stabilizers. So you can see here, as this is pushed out, those little stabilizers come as little hooks, they stay there. Right, so that means that and we tested this, deflate that, and then you've got a very secure temporary pacing system that you can easily remove. So that was some of the technology that we did. I've also brought along some pacemakers and pacing leads, and a new one of these if anybody's interested. I want to change tack now and talk about the disease itself, atrial fibrillation, which many of you will be familiar with, but some of you, I imagine, won't be. So it's the most common sustained cardiac arrhythmia. Kevin Jamar, where are you? Kevin, thank you for, these were really good slides. I talk about AF all the time, and you showed me the slides, and I thought I could steal those ones. So thanks, Kevin. And so this is approximately 2% of the population, of the adult population. If you're over 40, which some of you may be, not willing to judge, about a quarter of you will experience AF in your lifetime. And it's an atrial arrhythmia. As you can see, the normal situation here is a regular heart rate with a P wave, Q rate, and T wave, and activation of the atria followed by activation of the ventricles. Whereas in atrial fibrillation, the heart rate's irregular. And the way this is drawn here, we've got the 4 pulmonary veins at the back of the left atrium, which seem to be driving the process, and more on that later. So you get an irregular ventricular response. And the consequences of this are multiform. It can diminish the quality of life, cause fatigue, dizziness, and faintness, or it may be entirely asymptomatic. And one of the problems with it, if it is entirely asymptomatic, is that in fact, in some patients, it does increase your risk of stroke through blood clotting. So if you get a blood clot in the left atrium and then it's expelled from the left atrium into the systemic circulation, it goes to your brain, it occludes your cerebral vessel, and you have a stroke. And if you never knew you had it, then there's a limited opportunity to treat it until the stroke occurs. So what are the symptoms from atrial fibrillation? Well, it can be fatigue, breathlessness, some people feel dizzy or lightheaded, some patients feel palpitations like their heart's flopping around in their chest, some even get chest pain. But I think it's important to acknowledge that some patients get nothing. So once someone turns up with a hip replacement, somebody does an ECG as a pre-op check, and they're in atrial fibrillation. And there are 4 pillars of AF management. So there's rate control, which is just to slow the heart rate down and prevent the problems of a fast heart rate. The faster your heart rate goes, the more fatigued you are generally. There's rhythm control, which may be an opportunity to get someone back to a normal rhythm. There's anticoagulation or blood thinning to prevent those clots forming, to prevent the strokes. And then lastly, and this is one of the most recent pillars of AF management, is lifestyle changes. Increasingly recognise that atrial fibrillation is a disease of the Western lifestyle, obesity, hypertension, diabetes, sleep apnea, all that sort of stuff. It's also a disease of ageing. So, which I said is about a 2% burden. It's about, I tell patients, about 1% of 50-year-olds and 10% of 80-year-olds. So as you age, you're more likely to get atrial fibrillation. And you can see, like most cardiovascular diseases, it's more common in men than in women. Does AF increase mortality? Well, I tell my patients it's not a life-threatening rhythm problem. That's quite important because if you're 45 years old and you get your atrial fibrillation, you're admitted to hospital and you share a 6-bedded room with 5 85-year-olds, in your mind you're thinking, hell, that's me. And I think it's important to take the heat out of it for the patients and just say, look, this is not a life-threatening rhythm problem. We can manage it. It's a nuisance. It makes you feel unwell. It increases your risk of stroke. We can manage all these things, but you're not going to drop dead of it. But it's a bit of a white lie because there is a different mortality. So you can see, this is the percent of subjects dead in follow-up. It's a fairly binary outcome. And so you can see that if you don't have atrial fibrillation, the death rate is higher in this particular study, which actually I can't even remember where I got this slide from, but it does demonstrate the point that people with atrial fibrillation may have a higher mortality. That doesn't say that AF's killing you though, does it? So I think part of it is that AF keeps bad bedfellows, hypertension, diabetes, obesity, coronary disease, and that sort of thing. Okay, so it may not be the AF that kills you, but the things that go with it might. Now, When we talk about atrial fibrillation, we talk about a spectrum of disease from paroxysmal, that's episodes that last a short amount of time and self-resolve, through to persistent, where you can, it's there until somebody does something about it, chemical cardioversion, electrical cardioversion, or permanent, which is when sinus rhythm cannot be maintained. Or probably more accurately, is when the patient and the physician give up on keeping them back to a normal rhythm, right? So it's a clinical decision most often with a permanent. And whereas the paroxysmal tends to be trigger dominated, so that's to say that maybe the majority of the atrium is normal, but they're getting lots of ectopic beats coming from the pulmonary veins, which sets up the arrhythmia, but it cannot sustain for very long. That might be one end of the spectrum. The persistent atrial fibrillations, they may only have one trigger every 3 months or so, but once they're in a atrial fibrillation, it sustains and stays that way. All right, so there's one that's trigger dominated, one that's substrate dominated, or if you think about it another way, it's the seed in the soil, right? So you've got lots of seed in barren soil, you're not going to grow many plants. If you've got one seed in very fertile soil, you get the idea. How's AF triggered? Well, the current model of thinking, this is a left atrium looking from the back, this is pulmonary veins there, and the left atrial body. Excuse me. So pulmonary veins have ectopic activity which occurs and is conducted into the left atrium. It may be that there are colliding wave fronts, and they may set up this reentrant rhythm here with multiple reentrant wavelets. And eventually, so what we see, you can see the surface ECG at the top, and we've got some catheters in the heart. You can see the pulmonary veins firing very fast, setting up this process so that the surface ECG, what you see on the surface, is this fast, irregular heart rhythm. So we talked before about the 4 pillars of AF management. Up here we've got rhythm control. We can give patients drugs to keep them back into a normal rhythm. We can do ablations, which is what I do. And in some cases you can do surgery. That might be surgery because you're having a mitral valve operation anyway. It's like a drive-by. You're there, got the bonnet open, do a full service. Or it might be standalone surgery. The only reason you're doing surgery is because of atrial fibrillation, and sometimes that's done thoracoscopically rather than through an open sternotomy. And then there's rate control. That can be by drugs, using drugs to block the AV node so that the heart doesn't go quite so fast. Or you could put a pacemaker in, and you're thinking to yourself, why would a pacemaker work? A pacemaker only works when you've got a slow heart rate, right? These both got a fast heart rate. Put the pacemaker in, and then you burn the atrioventricular node. That means that the signals from the atrium, which are fibrillating, cannot get to the ventricles. Without the pacemaker, the heart's going to go 30 beats a minute, maybe 40. But cleverly, you put a pacemaker in first, and it's sort of the ultimate in rate control. But it's a bit of a one-way street, isn't it? You can't go back from an AV node ablation, you can't restore that. So it's often, although it's effective treatment, it's not our first choice, if you can imagine. Stroke prophylaxis. If I had atrial fibrillation, my risk of stroke wouldn't be higher than anybody else's because I don't have any other comorbid diseases. But if I was over the age of 65, if I had high blood pressure, if I had diabetes, if I had heart failure, if I had coronary disease, if I was female, I might have a higher risk of stroke. So if my CHADS VASC score, which is those things I just talked about, was 2 or more, then I'd probably be on an anticoagulant. Previously warfarin, now one of the novel anticoagulants like dabigatran or rivaroxaban. And so that's an individualised thing. Now maybe my CHADS VASC score was 1 or 2, and I had an intracranial hemorrhage 2 years ago. Now I'm not going to want to take a blood thinner, so probably we wouldn't give me a blood thinner. But if my CHADS VASC score was 4 or 5, I might be willing to take that risk. On the other hand, if I spent 10 years of my life caring for my mother who had a stroke, and I had no bleeding problems, maybe I'd take blood thinners or a CHADS VASC score of 1, because I know what every patient brings to the clinic their own ideas of what's important and what's not. And then there's the risk factors that the patients control. That's weight, that's sleep apnea, blood pressure, alcohol, exercise, that sort of thing. So we talked about rate control. Controlling the heart rate in the ventricles is really important. If the heart rate's over 110 consistently, generally people develop a tachycardia-related cardiomyopathy. So like the car's stuck in high gear, right? Or low gear, over-revving. So what we do to slow it down, we can use beta blockers, calcium channel blockers, we can use digoxin. And these don't actually get you back to a normal rhythm, but they prevent the ventricles from going very fast. And sometimes that's all patients need. You leave them in atrial fibrillation, they're 80 years old, they're not that symptomatic, they get a bit breathless when they're climbing the stairs. You slow their heart rate from an average of 100 to an average of 70, and they're fine. And you protected them from their stroke, and you're not doing anything, not giving them toxic drugs or doing an ablation. Rhythm control strategies is when you restore the normal heart rhythm wherever possible, with the aim of reducing the symptoms and decreasing the stress of the heart. And it's really about symptoms, to be honest. And so what we can do is put the patient to sleep and apply a DC shock to the chest, a cardioversion, and that gets them back to normal rhythm. So here's the patient in atrial fibrillation here, irregular baseline, regular heart rate, shock, and resumption of sinus rhythm. Beautiful. You haven't done anything to change the underlying problem, but you've temporarily, hopefully permanently, got them back to sinus rhythm. You may need the assistance of one of these drugs to achieve or maintain sinus rhythm. And each of these drugs have problems. Amiodarone, I tell my patients amiodarone is fabulous for the heart, best antiarrhythmic drug we've got. Terrible for the rest of the body. Thyroid problems, lung problems, liver problems, skin problems, eyes. You get the idea, And in fact, if you read the drug information sheet, you're probably never going to take it. Right? So we tell them not to do that. And for me, I don't use it as a destination therapy. It's a bridge to get me somewhere, to ablation, to some other correction of something. I don't use it long term if I can avoid it. Then the other kind of rhythm control that I employ is atrial fibrillation ablation. So what I'm doing is I'm bringing catheters up to the heart, a little bit like these, and I am putting a barrier into conduction between those pulmonary veins, which were identified as the problem, and the left atrium. So here I've taken a catheter and I'm doing burns here at the ostia, or the mouth of the pulmonary veins, hopefully a contiguous lesion, so that any electrical signals come out here are not going to propagate to the rest of the left atrium, which is happily in sinus rhythm there. And you can immediately see what some of the weaknesses to this might be. I might leave gaps in my lines. I might create problems by putting burns and creating a reentrant rhythm, so that the tachycardia might go around the pulmonary vein. There's all sorts of potential problems with this, but this is the strategy that we employ most often. So how does it work? So I did one of these yesterday, and I put 3 punctures in the femoral vein, wires up into the heart. That gets me pretty straight from the IVC into the right atrium. I want to then go into the left atrium where the pulmonary veins are, and I need to do a transeptal puncture. How do you do that? Very carefully. So we have a very long needle and a sheath, and we have 5 different checks. We look at the X-ray, we aspirate bright red blood from the systemic circulation, we inject contrast, we look at the pressure trace, and finally we put a wire out it, make sure we leave the heart shadow by means of the pulmonary veins before we dilate with, and I've done it once. I have put, my fellow, but I was supervising, we ended up with an 8 French sheath, a 3mm sheath in the aorta, right? So then you have to phone a friend. It's quite an embarrassing thing to have to do, but you rely on your mates to bail you out sometimes. So we treat it with respect, and that's how we get there. Once we're there, we have these catheters here, and we burn around the pulmonary vein ostia here, hopefully a contiguous lesion. In this particular animation, we've also burned around the superior vena cava. And we're going to be careful about our surrounding structures. At the back of the left atrium, you don't want to burn a hole through the esophagus. Around the FCC, we've got the right side of the phrenic nerve coming quite close. You don't want to damage the phrenic nerve, because otherwise your diaphragms won't work properly. So there's a number of considerations. Once we're in the left atrium, we're filling people full of heparin, blood thinners, because any clots that happen on my catheter, we don't want to leave the atrium and go to the brain and cause a stroke. So lots of things that we're thinking about when we're doing these things. Coming back to the technology theme, which I'm trying to bring through in the talk, is that it's still evolving. So the first atrial fibrillation ablation paper in New England Journal in 1998 from Bordeaux described a procedure with point-by-point radiofrequency ablation. So that is to say, there's my mouth of my pulmonary vein. I burn here, I burn here, I burn here, I burn here. You get the idea, 20 to 30 seconds at each site. All right. Hopefully I don't leave any gaps. Hopefully I don't damage anything with my burning. And that's how it's done. We now have 3D mapping systems to help us. That's when I told you I can see and without using the X-ray, I can see where my catheter is at any time, at any point in space, and I can move it around there. But it's virtual. It's not real. It's just there's lots of things that can go wrong between the recording and the visualization. So I don't trust it fully. I trust the X-rays because I know how they work. And I trust the electrograms because that's giving me accurate information. But the virtual reality, the 3D mapping system lies. But they're helpful. But we can now use cryoablation to freeze the veins. We can. Some people use laser. I haven't. Ultrasound. Westmead Hospital in Sydney were using microwave to ablate. I thought that was quite good because obviously you get the ding at the end and tell you you're done. Our longest experience is with radiofrequency ablation, but these other energy sources are very good, and cryoablation's got really good evidence. And sometimes more than one procedure is required. So when you're counselling a patient to say, I think this is going to be a good thing for you to have this ablation, you have to counsel them that a second procedure may be necessary. In fact, for some of the patients, you say this is a 2-procedure course. If you get away with one, that's great. This is the point-by-point RF ablation. This is 3D mapping. So here's my catheter, the little green tip thing there. And if I move it around, you can see, I don't know if you can see that moving around the patient. This is a CT scan that we did before the procedure, and we've registered the CT scan with our electroanatomical map. And you can see how I can see where I'm moving without stepping on the X-ray pill. That's nice for the patients. There's no less X-ray exposure for them. It's really nice for me too, because I'm in there most days. And I'm wearing lead and stuff, and even all that, I want X-ray exposure, so that's good. This is the types of ablation. So here you see a posterior view of the left atrium. You can see you've done, there's the left superior, left inferior, right superior, right inferior. You've done some lesions around the left-sided veins. You've done lesions around the right-sided vein. Also done what's called a roof line between the top of the veins here, and a box lesion, so box off the posterior wall, which some people do. You can look from behind like this. You can look from inside. You can cut away and look inside. We call an endoscopy view. So like a gastroscopist might look at the stomach. It's like you're on the inside of the heart looking at the things there. And this is the cryoablation. This is a cryo balloon. So this is the procedure I did yesterday. So effectively we had a wire from the outside wheel through the femoral vein, up the IVC, into the right atrium, across the interactive septum, through the left atrium and out the pulmonary vein, right? Wire all the way. And we slide this balloon along there, a 28mm balloon, and once we get it into the left atrium, we inflate it with nitrous oxide. We push it up against the vein. So you can see here, I don't know if you can see, this is the vein here. This is a catheter here, electrical circular catheter, which is recording electrical activity. And this is the balloon here. The balloon is pushed up against that vein so it's occluded temporarily. There is dye injected beyond that balloon. If there's a leak, the dye will wash away. If there's occlusion, like there is here, you'll see the dye hang up. Once you've got occlusion, you know you've got circumferential contact, and you take the balloon down to -50, -60 degrees for about 3 minutes or so. And that isolates the vein. So this is what we do to do it. This is a venogram, so this is the catheter. This is the interatrial septum here, so it's made out of puncture. We're injecting dye here. That's the right inferior pulmonary vein that we can see here. That's going to be our target. And this is the balloon here, occluding that right inferior pulmonary vein, and you see the dye hanging up here. And what happens, what we see on our EP system, and I know you guys are a bit unfamiliar with this, this is the only electrograms I'm going to show, I think. You can see here the surface ECG at the top. You've got the coronary sinus ECG at the bottom, and you've got the pulmonary vein in white here. That's that circular catheter. I don't know if you get the idea that the activation is rapid and irregular. It slows further, and it stops. And that's the point of isolation, the point at which the pulmonary veins are isolated. And we do that for all 4 veins. So this was subjected to a trial, I think it's a year before last now, rather catchy name, the Fire and Ice trial. And as you can imagine, patients were randomised to either radiofrequency ablation or cryoablation. And this is how we did it. I don't really need to know terribly much about it, but you can see the point-by-point nature of that. This time, the point-by-point nature of that ablation. And this is, cryoablation belongs to the family of one-shots. So you put your thing in, you have radiofrequency catheters that do this as well. You put it in there and you just do it all at once. And so this is the outcome, primary efficacy outcome. So what does this tell us? Subjects with primary, so this is success of AF ablation, right? So 35% success failure rate. This is in fact. So 65% of patients that worked, no AF, more than 30 seconds in the following year. So exactly the same efficacy. Safety endpoint, exactly the same. What was different between the 2 techniques was the procedure time was less for cryoablation, 124 minutes versus 141. I mean, to be honest, you know, my fastest time's now 54 minutes. When I started doing AF ablation, it was 3 or 4 hours. So you can imagine how much that's changed our workflow. The other thing is the standard deviation of procedure time is small too. So some You can do a radiofrequency catheter ablation in 90 minutes, but sometimes it'll take you 3.5 hours, whereas with cryoablation it generally takes, about an hour and a half, maybe 2 hours, no more. You spend less time in the left atrium. Time in the left atrium is borrowed time. You don't want to be there longer than you have to because of the clots and the dangers of being in the left atrium. But it comes at a cost in that there's more fluoroscopy time. My foot is on the fluoroscopy pedal more for cryoablation than with a radiofrequency ablation. I talked before about ablating pace. The reason I want to mention it again is if we can't control the rate with drugs, we can put a pacemaker in. All the conduction comes through the conducting system. Here's the AV node here, the atrial fibrillating. The conduction goes through here. We burn the AV node, and then the pacemaker takes over. However, when we come to technology, things are improving all the time. So whereas previously we would put a pacemaker lead, as demonstrated here, at the tip of the right ventricle, what's proposed is that you actually screw your ventricular lead into the AV node or the His bundle, which is actually just like the atrial side of the tricuspid valve. So you've got no leads going through the tricuspid valve, which helps tricuspid valve function. But it also helps in other ways. If you've got traditional ventricular pacing, it gives a broad complex QRS. You're not using the native conducting system. So, normally when your heart's contracting, everything's contracting at once. Everything's over and done within 90 to 100 milliseconds, right? If you've got a broad complex, you've got 160 milliseconds. You're going to go septum first, then lateral wall. So this is what your heart's doing. That's a very inefficient way for a pump to work, right? This is much better. So they have a dysynchronous contraction. If we screw the lead into the His bundle, you get a narrow QRS because you're using the conducting system, and you don't get dysynchrony. Right? So here you've got your normal intrinsic conduction here, nice narrow QRS. Here's what happens if you pace the right ventricle with a broad QRS. Here's what happens if you pace His bundle. It looks exactly the same as that. However, it generally takes more energy to stimulate it. So instead of a threshold of 0.5 volt, it might be 2.5 volts. What's the problem with that? Well, your pacemaker that lasts 10 or 12 years might last 5 or 6 years. And there's all sorts of other issues with sensing. There's issues getting it there. So this here is a His bundle pacing lead. I've got some pacemaker leads over here. The traditional ones with the stilet driven, they've got a hole in the middle of them. You put a stilet in it, you go where you want to go, you bend your stilet if you need to, direct it. This is catheter driven. All right? It's a solid single piece of metal, and it's got a little tiny screw on the end of it. So there's all sorts of technology that's coming. We've been approached by Boston Scientific to see if we can come up with better tools to do this. So AF treatment is quite complex. Patients can ride these escalators between anticoagulation, ablation, lifestyle modification, changing drugs, cardioversion, going for surgery, ablation, coming back for a surgeon, everything fails, put a device in, blow the AV node, all the time you're on anticoagulation or possibly not. And there's lots of things to move around. And I think this is where technology is really helping us. So we're in the age now of wearables and implantables. This is an implantable device. I hope to bring one, but I didn't have one. It's tiny. Oops. This is this thing here. You inject it, right? This is an injector machine. You just make a little cut here, and you literally inject it underneath the skin. It's like chipping the dog. And so it's tiny. A battery lasts 3 years. It has telemetry to this thing that goes by your bedside, which can then send information to somewhere else in the world. It's got some really cool engineering involved. This is the Lorentz plot. This plots the delta RR against the delta RR on the beat just gone, right? And so in atrial fibrillation, you can see that the rhythm is irregularly irregular. So this is plotting on this thing where it all goes, right? So if you've got an irregular heartbeat, it's purely irregular, then your Lorentz plot is going to show a complete scatter of all your speed that up, right? And so if you're going to, this is a patient in sinus rhythm, all the points are going to be in the middle because RR, there's no delta RR, it's all the same, right? As soon as the patient goes to atrial fibrillation, you'll see the Lorentz plot completely change. There we go. Patient's in atrial fibrillation, it's kind of obvious when you look at it like that, isn't it? When the patient goes back to sinus rhythm, it should then centralise back to the midpoint. To get, and these are the signatures: sinus rhythm, premature atrial complexes, premature atrial complexes will weaken back conduction, and you can see there's a gradient of different rhythm problems that gives you a probability of this being atrial fibrillation. It also looks at the P waves, and it has this P wave sensing thing. It looks for regular RR intervals, right? patient's sinus rhythm, looks at a regular RR. If he finds a regular RR interval, takes those two. Next one is too early, so ditches it. Third one's good. Gets the fourth. Once it gets 4 of them, it then says, okay, that's what our P wave looks like. And it constantly updates this. So, here's 1, 2, 3, 4, increment the P wave evidence. 1, 2, 3, 4, so I'm missing these two because they're irregular, increment the P wave evidence. Bit of noise in the trace, don't increment. 1, 2, 3, 4, increment the evidence. So it starts to recognise what a P wave looks like, and it looks at the Lorentz plot. So first of all, the algorithm goes something like R wave sensing, do the Lorentz plot, is there AF evidence, gives it a score. It also looks at the P wave features, looks at the morphology of the P wave, gives the P wave evidence score, and eventually tells you whether the patient has atrial fibrillation or not. Why is this useful? Well, you talk about the patient who comes in with, there's patients who get symptoms. The patients, I'd say, turn up for their procedure at hospitals and notice that they're in atrial fibrillation, they're not feeling it. We don't want to treat those patients because of their symptoms, because they don't have any. Difficult to make an asymptomatic patient feel better. But if they have those risk factors for stroke that I talked about, they are at increased risk for stroke. Right, so you might want to implant these devices to see if they turn up with their stroke, there's no obvious reason why they have stroke, they haven't got carotid stenoses, they haven't got clot elsewhere, and you might want to see, well, do they have atrial fibrillation? If they did have atrial fibrillation, then there's an opportunity to intervene with anticoagulation to prevent future strokes. Wearables. This is the new thing. Sorry about the marketing. This is what they're trying to. I couldn't get anything else, but this is from the leaders who brought you. And so this is a sense. We get a packet of 4 of these, so that will last a week each. And you stick them on the skin. You can wear them for a month. It communicates with the wireless transmitter, so that's the wireless transmitter there, and that sends it via the cellular network to a central repository. The patients can push the button on the device here, and they will record their ECG. So, I'm feeling my symptoms, I'm feeling a bit dizzy, I'm hypoplastic, I press the button. That's one way to get a report. The other way is automatically. If the heart rate goes below 40 beats per minute, it'll send it away. If it goes above 150 beats per minute, it'll send something away. This is the main project for my PhD in one slide. You'll be pleased it's just the one slide. Oh my God, you know how many hours went into it. But I just wanted to see where we've gone from 10 years ago to where we are now. So my conclusion was that for patients with low atrial fibrillation, no blood pressure problems, no sleep apnea, no diabetes, none of those things that gave us a cause for the AF, what did they have? Well, they had structural abnormalities. Their left atrium was bigger, and they were a greater volume. The conduction abnormalities, the conduction was slower, there were more fractionated signals, there were more double potentials. What was happening to the sinus node? Well, the sinus node recovery time was longer. There was evidence of sinus node dysfunction. And coupled with that was an increased atrial refractoriness, which until then hadn't really been shown because people assumed it had gone down because of the AF begets AF model. But this is a bit about structure, and this is what other people in my research group, there's no matter what the problem was, aging, hypertension, heart failure, sleep apnea, for me, low AF, we had similar changes seen across the AF, across the paradigm. So this is what we're doing now. This is back to Kevin's slide. Thanks, Kevin. So different levels of modelling. There's a remodelling. Cellular levels, there's fibrosis at the tissue level, and at the organ level there's dilation of different structures in the heart. There's fibrosis, which is generally collagen, but maybe even fat infiltration of the posterior wall. And whatever the fibrosis cause, it interferes with normal electrical conduction. So you don't get the smooth wavefront electrical activation going across your atrium. You get anisotropic conduction, you get barriers, you get fixed or functional barriers where re-entry you get the idea. And this all leads to a situation where you're prone to arrhythmia. So what we're doing here, Zishao as well, we're doing some MRIs. So we're assessing the fibrosis by using gadolinium enhanced MRI, and we're segmenting out the atrium. You can see here that atrium has been segmented. This is following from work done overseas. This is from the Utah group, whether they have graded the amount of fibrosis in the atrium such that even if the patient has persistent atrial fibrillation and they have less than 10% fibrosis, their response to ablation treatment is going to be good. But if you have paroxysmal atrial fibrillation, which is traditionally easily treated by ablation, but you have a high Utah score, a lot of fibrosis, your response to atrial fibrillation ablation is going to be poor. So we're taking these MRI images, we're doing echoes as well, And I'm creating a voltage map at the time of, with permission of the patient, at the time of the procedure. So I'm seeing where is the scarring, where is the low voltage areas. And Kevin's then looking and saying, well, can I see evidence of fibrosis on the MRI in the same places that Martin saw his low voltage? And so, so far we're enrolling 6 patients, and you can see the sort of segmentation I'm not going to dwell on, but you can see that we're trying to see where the fibrosis is, and we hope that in the future that will inform our lesion sets. So we're working through this at the moment. We're looking at all these different parameters to try and figure out what's going on. Why is this important? Well, this is a study, this is the STAR-AF2 trial. So we thought that patients with persistent atrial fibrillation need more than just pulmonary vein isolation. If you just do the pulmonary veins, the successful ablation is not as good as paroxysmal. So traditionally people have done lines, they've done extra ablation. So this took about 500 patients and randomized them to PVI alone, PVI plus lines, that's a roof line and a mitral line, which is the bottom one, mitral line, roof line, mitral line, roof line, or fractional electrogram ablation. So wherever you find fractional electrograms, you ablate. Right, so you can see here, this is the, these patients, as they develop, their sort of survival curve goes down. The patient group that did the best, pulmonary vein isolation alone, which is kind of not what we thought. So actually doing more was harming the patients in terms of their recurrence. Unfortunately, the way the trial was designed, it was a 1-4-4 randomization protocol, so that only 60 patients were in the PVI group and 240 were in the other groups, because we thought actually we were doing patients with a PVI disservice, but not doing enough. So it wasn't really powered to show much of a difference. But this is where we say, well, the lesion sets that we were traditionally employing weren't doing any good. So can we be informed by something else about the atrium, the imaging, the MRIs before the patients, or can we do something at the time of the procedure to see what's going on? So this is panoramic mapping of atrial fibrillation, various things. This is the firm mapping. So this was a lot of heat, not so much light. But when it first came out, we were all onto it. We were thinking this is great. We're going to see where the rotors are. We can see where AF is coming from. Drivers. We're going to target these drivers. We're going to ablate 3 or 4 places, and it's all going to be done. And like all promising things, sometimes it doesn't pan out that way. This is the Bordeaux group who are doing ECG imaging, looking at rotors, looking at multi-electrode ECGs on the surface of the skin, doing CT scans and solving the inverse equation to then project those surface ECGs onto the left atrium. You can imagine the problems with that inhomogeneity of the conduction of the chest, issues with imaging and that sort of thing. The other thing is if you design a software approach to find rotors, you will find rotors. You plug it into a bathtub, it'll show you a rotor, plug it into the earth, it'll show you a rotor. So the mathematical side of it is still not quite great. And there's other things here, Carter finder that's new, that the inside array's been around forever. The problem with the inside array, it's a non-contact map. So what I would like to see, if I could design a catheter tomorrow, would be something that contacted all of the left atrium at the same time. And it was able to give high resolution information about the electrical activity, would be non-thrombogenic, easily deliverable, and possibly reusable, and then would get really good high resolution information into your computer model to give you decent data. Crap data in, crap data out, everybody knows that, right? So I think if we can improve that, that's the way I see things going. Just finally, it's not all about technology, all right? So you can't go home and have your cheeseburgers and your beer and just hope that technology is going to bail you out. You have to look at your lifestyle. So the legacy study here, these are people, this is not easy to watch. So weight loss, this is patients with atrial fibrillation. If you lost more than 10% of your weight gain, of your weight, then 86% AF-free survival. 3 to 9%, 66. If you didn't lose weight or gained weight, 40% AF-free survival. This is human data. Arrest AF, these patients had ablation. If you had ablation and you went to a risk factor management group where they reduced your calories, your alcohol, treated your sleep apnea, gave you a statin, and treated your diabetes, then your success rate from the Symonds procedure is 87%. If you did none of those things, 50-50, whether you got AF back again or not. And lastly, cardio fit. If you increased your it's nets, I think, isn't it? Yeah. So if you get weight loss and increase your fitness, your success rate is 94%. If you had weight loss but didn't increase your fitness, 81%. And you see the people who did worse were those who didn't lose weight and didn't get fit. So you can't rely on technology to bail you out. So just to sum up, In terms of technology for arrhythmia research, I think we're in the age of wearables and implantables. We can inject monitors to see what's going on. There are disposable, fairly straightforward monitors, and recently the Apple Watch 4. I suspect this will increase my referral rate in socioeconomic class 1 and 2 who can afford them, and there'll be a lot of worried well out there, so I'm sort of bracing for that. Imaging, we're talking about the imaging itself, how we process it. Part of which I haven't touched on, part of Kevin's project is about machine learning and how we can get the most out of the scan. We can co-register one image with another image modality to increase the power of what we do. And then finally, in terms of treatment, I think there's a space here for catheter design, about how we deliver things safely and effectively, the energy sources that we apply to the atria to get rid of these problems, all the ventricles for that matter, because we do the ventricular ablation, ablation aids, and also these implantable devices. So with that, I hope that's not gone on too long. I'm going to say thanks very much for having me. Cheers.
Okay. Any question for Martin?
Thanks, Martin. Great talk. It was a small part of your talk, but I'm quite interested in the lone AF.
Yes.
So those things that you listed, were those things that you observed after they obviously came to the clinic? So they had AF for
yes.
at least a short period of time.
Yeah.
And so how much of that is due to the fact that they've had AF?
So how the study worked was we looked at patients with lone atrial fibrillation. Now, lone atrial fibrillation is getting increasingly rare because we're learning more about why people have AF, right? So whereas previously we didn't realise that sleep apnea was a strong thing for AF, we didn't then. So we looked at diabetes, hypertension, valvular heart disease, heart failure, coronary disease, a bunch of other stuff. And so we didn't have a reason for atrial fibrillation, and we took a detailed map of the left atrium just before we did an ablation, all sorts of things. We also had a group of people who were coming for an ablation who didn't have atrial fibrillation, our control group, and they required left atrial access, transeptal puncture, because they had a left-sided accessory pathway, like a Wolff-Parkinson-White sort of scenario. Okay, so those were our control group, and those were how we compared them. And the other important thing about the study is that we made sure that the patients who were having the study, the lone AF patients, hadn't had AF for the previous week. Because, as you probably know, AF begets AF. The seminal paper showing in goats that if you induce AF, the more you induce AF, the more easily it is they get AF and the longer they stay in it. So we wanted to avoid that electrical remodelling, because what they demonstrated in those goats was that the effective refractory period of the atria reduced, or the APD shortened, or whatever way you want to look at it. And so that would promote atrial fibrillation. What we found that is remote from episodes of atrial arrhythmia, the effective refractory period was actually up. So therefore, you couldn't have a reduction in effective refractory period wasn't the cause of your atrial fibrillation, at least initially. It was the structural changes. It makes sense, right? Because something's got to give you AF in the first place. You can't say AF begets AF and think, well, what happened the first time? So yeah, that's how we did it. Could you do it today? I think the group would be smaller. You're thinking of other reasons that people would have AF other than just the things that we tested for.
So Martin, you said lone AF has synoatrial node.
Synoatrial node impairment, yeah.
So why is that?
Yeah, I don't know. I mean, we certainly see this in the syndrome tachybrady syndrome. So, six sinus syndrome, the patients, we see them in atrial fibrillation or atrial flutter. Atrial fibrillation terminates, or the atrial arrhythmia terminates, and the sinus node has a big pause. It's almost like the sinus node's gone on holiday. It hasn't been needed for, weeks at a time because the patient's been in a tachycardia, and it's found wanting. But it always amazes me when you cardiovert somebody. They might have been an AF for 6 months, and you cardiovert them, and then look, there it is, sinus node just ready to go 1 second later. Unbelievable, really, isn't it? That it actually works. It's really there waiting to go. But in some patients who have sinus node disease, it's impaired. One other part of my PhD was doing about patients with atrial flutters, they had chronic atrial flutter, and we terminated their atrial flutter, and we saw where their sinus node activated from. And generally, it was more caudal or inferior than the control group, which was more cranial. And that goes with our model of the sinus node being a small histological feature, but physiologically having a sinus node complex and having different breakout points. around the atria, because there's got to be some redundancy in a sinus node. If you think about it from an evolutionary point of view, your sinus node has to be isolated from the large amount of myocardium that's around it, because it's got to function independently. Yet, it's got to propagate its beat to the rest of the heart seamlessly. And those two things actually oppose each other. So it's quite clever how it's designed to be insulated from the rest of the heart, yet have these connection points that allow it to rule the rest of the heart.
So clinically, you can also measure the breakthrough with synaptic node where you level.
Yeah, we can measure it clinically. One of the simplest things to do is what we call sinus node recovery time. So you pace the heart, pace the atria at 100 beats per minute for a minute, and then you stop, and then you record the time to the first sinus node beat. That's all it is, right? And you'll see patients who have heart failure, hypertension, sleep apnea. They will have a longer sinus node recovery time. And I think it just implies fibrosis of the atria, really.
I heard a talk recently by Adam Bartlett, who's a liver surgeon at Auckland Hospital, and he was saying that they've moved to an ablation technique in liver surgery now, where they use electroporation or some technique that essentially takes the cells and they decellularize the region, but they leave the tissue structure intact. Is that being investigated?
I've heard of it, but it's certainly not mainstream. Yeah, I've heard of this electroporation technique. I mean, ideally, you'd want to sort of induce apoptosis or something, wouldn't you? Where you could, leave the structure intact. One of the things about cryoablation, which I didn't talk about, is that if you look histologically, once you radiofrequency ablation, you get a lot of neutrophils, macrophages and stuff in the tissue, a lot of inflammation. Whereas with cryoablation, you tend to get a more fibrotic kind of, less inflammatory kind of. So the proponents of cryoablation will say it's less injurious to the tissue. I don't know if that's necessarily the truth or not. I like it because it's quicker. The other thing is once you freeze, you leave it there for 3 minutes. Once it's got to minus 30, minus 40 degrees, it's like sticking your tongue on the freezer. Not that anyone's done that, right? But it sticks there, so I can let my catheter go. And I can, and we could just wait for the next 3 minutes. The main thing is to have a bunch of witty anecdotes to entertain the nursing staff with. If you have radiofrequency, but you're constantly the whole time working, and it's exhausting actually. So I like it from a workflow point of view. But you can imagine how these one-shot techniques are really taking off around the world. So at the moment, Christchurch are looking at a one-shot technique, radiofrequency ablation. So it looks similar to a balloon, but it's radiofrequency energy, one shot, made by Boston Scientific called Palmer. I was going to put it in, but I didn't get around to it. Auckland Hospital are looking at a Me Too cryoablation. Yeah, so there's plenty of people. If you're in America, you've got 2% of the adult population, 500 per million getting an ablation every year. You do the maths. It's big money.
Thank you very much for the nice review on AF technologies. I have a couple of questions. One, you haven't commented on left atrial appendage related therapies, including the occlusion devices, but also the ablation and the isolation that these days some people are starting to...
So the left atrial appendage has been proposed as a source of atrial fibrillation. But basically I think about it as anything annexed to the atria is a potential source of AF. So that's the four pulmonary veins, the coronary sinus, the SVC, not really the IVC as it turns out, and the appendages, right and left. And so, particularly Andre Natali in Texas, he is advocating for patients who have persistent atrial fibrillation, long-standing persistent atrial fibrillation, isolating the left atrial appendage. Now, if you isolate the left atrial appendage, which I have done in the past, then you have no electrical activity in that appendage, and so the appendage doesn't empty with every beat. Okay, so you're committing that patient to lifelong anticoagulation because you've got a blind sac that's not contracting. So that's the first thing to say. That might be appropriate, but I think you need to acknowledge that that's what you're doing. You're committing them to anticoagulation. It's difficult to do. It's a lot of ablation. I've done it inadvertently a few times because I've just done so much ablation that's happened. I don't do it routinely, but you can do it. The next question is the left atrial appendage occlusion device. So it's thought that 95% of clots from atrial fibrillation come from left atrial appendage. So the idea being is that instead of taking warfarin, you can occlude the left atrial appendage, no blood getting in, no blood clotting, no blood getting out and causing strokes. And so you can occlude the left atrial appendage and then come off your warfarin or your novel anticoagulant. And if you think about this, there could be, the studies were done in people who could take warfarin and they got randomized to warfarin or appendage occlusion devices. But the real money is for people who are bleeding, right? If you've got someone who's got recurrent bleeding gastric ulcers or intracranial hemorrhage or something where you really don't want them to bleed, then actually a left atrial appendage occlusion device is quite attractive because it's a non-anticoagulant alternative. Whereas some of the manufacturers of these things are promoting as a lifestyle alternative. You don't have to, you can come and have a 1 hour procedure and not take anticoagulation for the rest of your life. You know, it's more of a choice thing than a necessity. I haven't done any. The data is controversial. There's a lot of controversial data about it. You know, I had a conversation with the Southern Cross Insurance Company last year. They don't fund pacemakers. It's only been 60 years that we've had them. I didn't realise until this meeting that they actually fund left atrial appendage occlusion devices. I literally choked with the water I was drinking at the time, and the lab manager kicked me under the table and said, shh, we want to do this, because she wants to put money out of it, right? So, you know, it's really, it's taken off, it's taken a lot of interest, left atrial appendage occlusion devices, and I think it'll get increasingly more common. There are some of my colleagues in Australia who do an AF ablation, and because they're in the left atrium, they'll plug the appendage at the same time. It's a little bit negative though, isn't it? We're going to fix your AF ablate, we'll fix your AF by ablating you, but just in case we don't, we're going to pop this plug in.
And the other comment is, it was very interesting because you mentioned that you don't trust really the 3D anatomical, electroanatomical maps.
It's getting better.
Comparing to X-ray. I mean, X-ray for engineers is like magic, how clinicians you can really see something there.
Yeah.
So for us it's a bit difficult also to trust X-ray as it is right now. But also you're mentioning that you're more and more comparing MR with electrical information.
Yeah.
And this is really tricky also, because there is no grand truth. I mean, there are two different physical phenomena that are related to some extent, but we don't know how.
So at the very simplest level, we could take a voltage map of the atrium and then say, well, the bit that looks scarred on MRI, the voltage should be less. And the bit that looks healthy, the voltage should be greater. I'm not even sure if we've shown that. You know, at that basic level.
You will have places where you will have contradictory information.
Yeah.
And you see groups that they are really fond of MR and they just trust MR, and etc. And others don't trust, they just trust electrical information.
Yeah.
And we don't have ground truth.
And it depends, you know, if you're a radiologist, you'll trust the MR. If you're an electrophysiologist, you trust the signals.
Exactly.
You know, and when I say I don't trust, that's unfair. I do trust the maps. But, you know, it doesn't take much for, you know, a patch to shift and all of a sudden the map shifted, you know, and you can be false. One of the things you want to do is stay out of the veins. You want to burn around the mouth of the veins. If you burn in the veins, you get stenosis, the patient gets breathless. You want to stay in the mouth of the vein. So if the map's telling you you're in the mouth of the vein, but actually you're in the vein, that's bad. That's false reassurance, you know. So that's why I have a healthy suspicion. And the thing about X-ray is very simple. You shine light through the patient, you record it, that's where your metal catheter is, you know. And same with electrical activity. You have a bipolar electrogram, you pass it through a bunch of filters, but that's the truth. By the time you've got your patches, your impedance changes, the patient's sweating, the patient's moving, you know, plus your fudge factor that they apply, I just want to ground in reality, and you just don't have the luxury to be fully trusting, because you're responsible to the patient.
Given the susceptibility of the pulmonary veins, what do we know about what's generating this aberrant activity? Because you're throwing in barriers to try and stop this propagating activity affecting your atria.
Yeah.
Another strategy would be to go to the point cause of where this aberrant generation initiates, which probably in many cases is the pulmonary veins. So what is it about these vascular smooth muscle cells that makes them so susceptible to the extent of the population for generating this activity?
Well, you know, it's a really interesting question. In fact, if you look at the original 1998 paper that I mentioned for Bordeaux, they did go to the triggers, right? So that they put the patients on isoprenaline or adrenaline or whatever, and they put catheters everywhere, and they found out where the trigger was coming from, and they went and ablated the trigger, which happened to be in the pulmonary vein, and more, in most cases, 87% of them, right? So that was the original thing. They went for the triggers, but it's a very long and laborious thing. And the other thing is that all the pulmonary veins are really subject to the same conditions. So whether it might be the right superior on a Tuesday, it might be the left inferior on a Thursday. Do you know what I mean? So the sort of paradigm shifted to just kind of isolating the whole lot at once. Why they do it, I don't know. One of the really interesting things that's come out of the genome-wide association studies is the PIDX2 locus. So, you know, if you look, these GWAS studies, this PIDX2 lights up like a light bulb for AF, risk for AF. What does PIDX2 do? Well, apparently it codes for the laterality of the heart, right? So we're all born, you know, with the heart's like two tubes, right? And then it differentiates into your left ventricle and your right atrium and that sort of stuff. And so laterality in my mind says, well, that's going to make you the sinus node on the right, that's going to make you the pulmonary vein on the left, because they're both the smooth, not the trabeculated part, the smooth part of the atrium, right? So you can say, well, there's a certain amount of automaticity. If your PIDX2 is not working, maybe your automaticity, which is supposed to be shut down on the left, is somehow still regulated. You know, it would be nice to design a drug or some way of targeting that specifically. My experience with cardiac drugs is the more specific you become in your target, the more collateral damage is done. You know, like an amiodarone is a really dirty drug. It blocks every channel you can think of, right? But damn it, it works. You know, and you come up with, you know, I'm trying to think of the name of the drug that, you know, targets just soul channels, and then, you know, it's great for AF, but everyone does some death from VF. You know what I mean? It's really fraught.
So it strikes me that the intrinsic cardiac ganglia
yes.
are amongst these big pulmonary veins, and you know, do you consider their potential role?
Yeah, they're really important, but yeah. So for those of you who don't know, the ganglionated plexi that are the nervous supply to the heart, really, the mini brain, if you like, of the heart, and they direct the traffic. And there's some really elegant studies showing, you know, you can see it acting distantly. You can put acetylcholine at the, you know, on these things, and you can find it stimulates something of the right atrial appendage, or something happens else in the left atrium, like obviously distant, coordinated through these things. And some people have looked at ganglionated plexi ablation. And one of the theories about AF ablation is that as it happens, they're quite close to the pulmonary veins. So it may be that taking out these ganglionated plexi actually improves your success rate. One of the things that we find, if we're ablating them up a pulmonary vein, we get asystole. Quite commonly, we get asystole. Yeah, you get asystole, so you're obviously interfering with the autonomic nervous system. Moreover, if you get an asystolic reaction while you're doing that, your success rate's better, right? Implying that damaging the nervous system is a good thing. Patients come back to my clinic, I say, how are you? Oh, you're great, have you AF? No, good. And I said, one thing is, you know, my heart rate's about 10 beats per minute faster than it always was. Particularly athletes, they're really proud of their 45 beats per minute heart rate because they're fit, right? They probably exercise the way to AF, which is another story. But, you know, they come back to clinic and the heart rate median's 80 or 70 or something. And over 12 months or so, presumably as the heart renovates, it comes down. They're quite worried about it, but it's actually quite a good thing. But man, is it crude. You know, it's on the outside of the heart, I'm blading it inside of the heart, I'm destroying it God knows how. It's not very elegant, is it? It's like a, yeah. One of the things I'm acutely aware of is we're destroying heart tissue. That can't be a good thing. So if you guys can figure out better ways to do it, that'd be awesome.
So, when you finish, you have a lecture.
Oh, of course. Sorry.